Welcome back to The Thinking Mind, a podcast all about psychiatry, psychotherapy, psychology, self-development, and related topics. Today, myself and my co-host, Dr. Anya Borissova, are coming back for our second episode where we discuss scientific research, by which I mean we're going to break down real scientific papers and discuss the insights that this research can give us as to the nature of mental and physical health problems and how we can treat them. But we also wanted to use these episodes to discuss and teach our listeners a bit about the scientific method itself, how science actually works, and the difference between good science and bad science. We really want to discuss how science is interpreted and reported in the media, mainstream media, on podcasts, and especially by people who want to sell things and products. Because obviously, as we know, we're now living in an ecosystem full of misinformation. And for that reason, I think it's really important that people understand a little bit about how science works, so people are better equipped to critically think about the things that they're told online and hopefully come to some better conclusions themselves. Today, we're going to be discussing 3 papers. The first one looks at a commercially available product sold by a company called Flow Neuroscience, specifically a device they sell that's used to treat depression. And so we're going to look at a study that looks at this device and how effective it is for treating depression. Secondly, we're going to look at a study that examines a large group of people in the real world taking the weight loss drug Ozempic and tries to establish whether or not taking Ozempic is a risk factor for developing psychiatric problems like depression. And the third paper, perhaps the strangest study we're going to look at today, is a paper published in the Journal of Gerontology in 2021, which looks at whether hydrogen-infused water has any effect on the biomarkers associated with aging. And I picked out this study specifically because it was referenced on a mainstream podcast. So very interesting stuff. As you hear on the interview itself, Anya is the best person on the team to discuss this with because she's an academic trainee, which means she's very much immersed in the research world and looking at and thinking about research and how science is conducted all the time. We hope that you, the listeners, will enjoy and get a lot out of this episode. If you'd like to support the podcast, do check out some of the services we offer in the description. Thanks for listening. And now here's today's conversation with Dr. Anya Borissova. Today we're going to be answering a few different questions. Can we stimulate our brains with currents at home to treat depression? Can Ozempic and other similar weight loss drugs cause depression? And lastly, can hydrogen water reverse aging? This is the second episode where we take a hard look at published research studies to help us answer questions about real-life mental health problems, helping our listeners to separate fact from fiction. With me to look at these studies under a microscope is our woman of science, Dr. Anya Borissova. Anya, thank you so much for joining me.
Hello, it's lovely to be here again.
Tell us about the first study we're going to be looking at.
So the first study we're going to talk about, I think, was super interesting because it looks at the effects of a home-based TDCS or transcranial direct current stimulation treatment for depression. We have probably all seen adverts for this home-based TDCS treatment. This study used the device called Flow, which is available in the UK pretty widely in Boots and I think maybe even Amazon. So it's really easy to get. It's got some lovely marketing. You know, its Instagram page is screaming about how great it is and how useful people find it. So it's really good to see that actually it's been tested out in a pretty decent trial. So this was a randomized controlled trial. So that's the gold standard of testing a new therapy.
Yeah, if you want to see if something's effective or not, you really want to do a randomized controlled trial.
Exactly. And the other good things about it is that it was a multi-site trial. So they had a couple of different places running the tests, running the intervention. And it had all the things that you would expect a good quality trial to have. So it was double blind, meaning that people who were participating didn't know what treatment they were receiving. And the people who were doing the assessments also didn't know what treatment the people were receiving. The fact that it was double blind also means that they had a control condition. So everyone received a device that sort of, as far as we can tell, looked the same and seemed similar. But one of the devices didn't deliver a proper electrical current and the other one did. And so I guess at this point, probably it's useful if I explain what TDCS actually means.
Yes.
So for our listeners who listened to our episode with Nolan Williams, which was a couple of years ago now, they will have probably heard about TMS, or transcranial magnetic stimulation.
Yeah.
Which is a similar treatment. And I guess in the simplest terms, TDCS is a bit like TMS, but it's milder in some ways. It can't get as deep into the brain and it's much less focused. So it acts over a much wider area in the brain.
So that's why I guess you can do TCS at home, whereas a magnetic stimulation, you need to be in a hospital or a clinic or something like that.
Exactly that. But clearly we can see why TDCS has got people interested, because if you can avoid the need for people to go to a clinic, if you can avoid the need for people to have to be in sort of a really controlled environment to have a treatment, then you're creating a real alternative to tablets.
Yeah. And I would also want to say at this stage, like I've seen the adverts for Flow, and in my mind, I almost like dismiss them immediately. It's almost like, this might be my bias, the nicer the advert is, the more I'm likely to disregard. It almost seems too good to be true, too convenient, too pristine looking. Maybe that's, again, my sort of medical bias, or my bias of in working in the NHS, where it feels like for something to have to work, it also has to be like semi-falling apart. It can't have like a nice commercial, sheen to it or something like that.
Well, exactly, because you're sort of wondering why are you having to make it look shinier? And exactly as you say, surely it can't be that good if it's so shiny. And do you also start to wonder, if it was that good, why don't we just have it in the NHS?
You're right.
Why isn't it really widely available already? And I think an important and a useful study to look at. So what did they do? So they had a sample size, or sort of the number of participants that they had was 87 in each group. So that's a reasonable study size. That's decent. That's kind of what you would hope for a single randomized controlled trial.
Just out of curiosity, what sort of number of participants in a trial is like your threshold when you start taking a trial kind of seriously? Do you have a precise number, or is it more of a range?
One of my colleagues used this phrase the other day. I feel like we often work on vibes. I think different people might have different answers. I would say when you're sort of nearing the 100 mark, by that I mean 100 participants in each group, that feels like something that you can take quite seriously. But having said that, I don't think it's an exact science.
So we had 87 in total, or 87 in each group?
87 in each group.
Okay.
The participants themselves, and this is where things look a little bit less good. So the diversity wasn't great. So it was an extremely white group. I think about 80% of participants were white. And that's important when you start to think about whether the results of the study are generalizable to you. So understanding who it was that was included helps you think, could this be useful for my patients, or could this be useful for me? They had a larger number of female participants, so it wasn't 50-50 male to female. And that's probably reasonable in a depression trial. We know that depression is more common in female people. Now, I think really key thing to look at when thinking about whether this is relevant to you or to patients is that the participants that they included hadn't had that many treatment trials before. So this wasn't the case of this being a last resort treatment. This wasn't the case that people had tried everything and then they got to Flow. If they tried more than 2 medication treatments before for their depression, they weren't eligible to participate.
Okay, so definitely not what we would call treatment resistant. And do we know whether their depression tended to be mild, moderate, severe?
They had a mix of people. So they had people who would probably meet criteria for moderate depression based on the scales that they used. And then they had a contingent of people who were more severe. So the split of that was, they kind of had more people on the moderate end, about half of them, and then a third of people were in the more severe end, and hence the other proportion were on the milder side.
And how are they measuring like depression severity and progress? Was it the Hamilton Depression Rating Scale?
Yeah, it's that one exactly, which is a scale that used to be, I think, the most commonly used scale in depression studies. It's a slightly funny one because it's got 3 questions about insomnia.
Okay.
Which I always find just strange. I mean, sleep is obviously a really important part of mental health and mental illness, but you ask people people can score kind of in 3 different ways depending on what kind of insomnia they have.
So it might overvalue sleep,
Exactly.
undervaluing something else.
Exactly. But they also used a couple other scales. So they used the MADRS, so the MADRS, which is nowadays tends to be the scale that more studies use, although again, that varies. And they also had a self-report version of that scale. So they used both clinician-rated scales, but also a self-report scale. So basically participants themselves could say how they were feeling, but also there would be a clinician making an arguably more objective rating.
How long did the study take? What was the time horizon for the study?
So this is another really key and a really useful part of this study. So kind of a way that this study really expands this field is that they did the study over 10 weeks. And the reason that they did that is because there'd been a meta-analysis done, I think, in the last couple of years, which basically showed that you really need to continue TDCS for over 6 weeks in order to see the clinical benefits of it.
Okay.
So that meta-analysis found that studies that continued for 10 weeks would find that the group receiving the sham treatment or the placebo treatment started to do less well at about that 6 to 10 week time point. So what this study does is, continues the study for longer than a lot of antidepressant trials go on for. I mean,
how long is a typical antidepressant trial?
It varies, but I'd say about 6 to 12 weeks is fairly typical, and 6 weeks is common. 4 weeks is also not uncommon.
And to a clinician, I guess, for the clinicians listening, I know they're thinking that's way too short because we need to follow up our patients for like months and years. And, to everyone listening, this is, really important to make sure these studies are timed correctly. I think about it in terms of ADHD, where, the longest follow-up studies are 2 years, which is long. But then if you're thinking, okay, but my patient who I might start on an ADHD medication might be on it for 3 years or 4 years, we start to get into uncharted territory really quickly. So really important to take time horizons into account, I think, with this kind of research.
Yeah, for sure. I mean, I think I remember at one of my first conferences that I ever went to, sort of hearing a presentation, and I think they'd followed up results over like 2 weeks.
Yeah.
And I think I put my hand up and I was like, you followed people up for 2 weeks, but depression goes on for years.
Yeah.
And I don't think they really answered the question, because obviously in the context of that conference, that was a silly question, because everyone knows that that's a perfectly reasonable length of time.
You would have come across as like very idealistic. You don't know the real world.
100%. And I
research.
didn't, but exactly as you say, to a clinician or to the average person who's experienced the illness, you think, ooh.
Can you tell me more about what the treatment looked like? They were wearing this headset. How long did it take? How many times a day did they have to use it?
It wasn't extremely onerous, actually. So they would have to wear the headset for 30 minutes a day, and that would be for 5 days of the week, which was for the first 7 weeks. And then they reduced the frequency for the final 3 weeks. So people went on to then just wear the headset 3 times a week for those final 3 weeks. They would get some remote supervision. So that's one key difference from what would happen if somebody bought a headset just from Boots. So here people would have video calls with someone on the study team who would check that they were putting the headset on sort of correctly, that they were positioning the leads, the electrodes correctly, and could obviously troubleshoot any issues. So some of the problems that occurred, for example, people didn't make the sponges wet enough, and that could lead to some of the adverse effects, which potentially, someone who's just doing this themselves at home may not realize. So it's worth having that in mind when thinking about how this applies.
And so you have your treatment group, they're getting the real deal, and then you have the sham control group. And they're getting a imitation of the headset, looks kind of the same, but not quite doing anything. Is that right?
Yeah, exactly. And the nice thing that they did is that they did get the sham headset to still produce like an electrical current at the start and at the end of the session.
Yeah.
So that people still had a feeling that something might be going on, which is a useful way to try to maintain blinding. Didn't quite work, I guess, as well as the authors probably wanted it to, but an important thing to try, and important that they weren't just, for example, putting people on a wait list and saying one set of people get the headset, the other people get nothing, and just sit on a wait list.
And just so people know, the purpose of the sham control is really to identify how much of this is placebo. Is that fair?
Yeah, exactly. People will probably get sick to death of hearing us talk about the placebo effect if they listen to multiple of these episodes. But it's just so important. And again, if you yourself are reading a study and you're trying to assess the quality of it, you want to look at what people did, especially when it comes to the treatment of psychiatric illness, because we know that the placebo rates are really high. I think a suspicion is that there's probably just something about being involved in a trial, having the support of a trial team is therapeutic in its own right. Doing something for your health is probably therapeutic in its own right. And then just the placebo effect in itself, our brains are really good at just making us believe that something is going on, even if in theory there isn't. So essential that you kind of control for that so that you give people something that allows you to tell how many people would just get better by themselves or how many people are getting better because of these non-specific reasons for improvement.
And presumably the participants couldn't be on any other treatment for depression, like an antidepressant. Is that right?
They could actually be. So they just had to be on a stable other treatment and to be happy to maintain that stability so that they wouldn't stop it suddenly whilst they were on the trial. And that included medication and included psychotherapy.
Okay. So after the 10 weeks, what did the results show?
They showed a pretty solid placebo response.
Which that's, I guess, speaks to the quality of the sham?
Yeah, exactly. I think speaks to the quality of the sham and is kind of what you would expect in any depression study. So I guess I'll say the results in two different ways, one of which is the actual changes in scores, which will sound probably not that impressive. And then I'll say it in terms of the response and the remission rates, which will sound way better, which is a nice quirk, I guess, of how studies are often reported. So people who got the real treatment on the primary outcome, which was the HDRS score, their scores got better by about 9 points, sort of 9 to 10 points. That sounds pretty good. A 9-point drop on a scale is good. But the people who got the sham treatment, their scores dropped by 7. So it gives you a difference of about 2 points between the groups. It was statistically significant. And here we may enter the territory of arguing whether we think that's clinically significant. I think what makes it sound and sort of certainly feel more clinically significant is that when you look at the percentage of people who responded to the treatment, and so that means that their scores dropped by at least 50%. So whatever score they started at the end of the 10 weeks, they had half the number of symptoms than they started with. So that was 58% of people in the treatment group, and it was 37.8, let's say 38% of people in the sham treatment group. So that gives you a difference of, I guess, about 20% between the two groups, which sounds a bit better than just 2 points. If you have the active treatment, 20% more people will get better than if you have a placebo treatment. The reason being is just kind of, I guess, a statistical quirk, is that because you are converting scores to a threshold, so all of a sudden people either meet a threshold or don't meet a threshold. So that means that you might have people kind of falling off the cliff of either being responders or not being responders.
Right.
So it's useful to sort of look at both bits of data, because one kind of gives you the, sort of the actual absolute difference between the groups. One gives you something that's a little bit more relative.
Yeah, so I'm wondering, like, within the treatment group, is it that you're seeing some people who have a really good response and some people who don't really respond at all? Is that fair to say?
So not necessarily. I think it's more that you might have people who are even hovering over the edge of having that 50% response, and a 1 point might make a difference to them becoming a 50% responder, or to mean that they stay in a non-responder group.
Okay. So what do you make of these results? Like, what do these results mean for you?
One is that these results are comparable to other treatments that we have. So in terms of psychotherapies, when you look at meta-analyses, and sorry, by meta-analysis, I mean a study which collects all the other studies that have been done and lets you get a really broad overview, sort of with thousands and thousands of participants, at what the true results are. There, the net improvement that people have is about 25%. So as in about 25% more people will get better with a psychotherapy than with a control or sham. So, it's comparable to that, which is decent and useful. The other useful things to know is that the rate of adverse events that they reported was reasonably low.
Low risk intervention.
Yeah, exactly. And I guess if you're comparing to things like medications, you're not seeing things like the risks of sexual side effects, nausea, weight gain, as far as they could tell, over a 10-week study. I guess withdrawal effects is true. We would assume that there wouldn't be because it's not a medication. But I guess what we don't know is what happens after that 10-week. So we don't have a long-term follow-up from this study. So we don't know, what did people just stop the treatment and then things got worse again? Did they have to continue giving the treatment to themselves, at least once a week, a couple times a week? Was it something that they would now be tied to for the rest of their lives?
Right.
So we can't answer that question.
Would they become dependent on it?
Yeah. Dependent, and again, we always have to be, I guess, careful with dependent, but dependent not in the sense of, craving the TDCS or feeling that they can't live without the TDCS, but just that is what is necessary for them to
feel okay.
Did
the authors talk about what the self-report scores were? Because we talked about the scores that were like clinician rated. So the doctor saw them and said, okay, this is your score on the scale. What was the patient's self-report?
So they were similar. So again, the difference in the actual scores was about 2 points. The difference on the response remission rates was again about 20-25%. So it matched what the clinicians were rating. I think what was interesting is that the quality of life scores didn't change, and tricky to know sort of why that might be. Maybe just that's something that you would see coming through later, that the study didn't quite go long enough to capture those things. So I guess that's another way that we might measure self-report, and we don't really know why there wasn't a difference there.
Now, you've talked about what you like about the study. It's a randomized controlled trial. It was double-blind. There was a good sham intervention. Depression was measured using a good rating scale with self-report. Were there any limitations of the study? Was there anything you would have liked to see in the study?
So again, people might get bored of me saying this, but look at who's paying for the study. So this was funded by Flow. The headsets were donated freely, but the study itself was funded by Flow as well. It stated clearly in the paper that they had no involvement in the design of the study, the analysis of the results.
Which research institutions carried out the study?
So there were two. So one was at a place that we know and love well, which was King's College London.
Just up the road?
Just up the road. And then the second one was in the States.
Okay.
So that's, I guess, one of the limitations. We've talked about some of the others, the fact that we haven't got a long-term follow-up to know what happens next. And we know that in terms of comparing this to the rest of the field and putting this together with what exists in the field, I wouldn't say this leads us to say that TDCS is definitely, a top-notch treatment for depression. The results are fairly mixed. There's plenty of studies that have been done that show no difference between the sham or placebo group and the active treatment group. Not necessarily using Flow, but using sort of other versions of TDCS. Okay. Exactly. And I guess the key thing for people thinking about how to take this away is the lack of any kind of monitoring if you're buying this at home. So it's, where you place the electrodes is quite important in TMS, TDCS, in these treatments, because you want to direct the electrical current to the right place. And without that support, without that remote support, it's unclear whether you would be getting the same results at home.
Going back to the funding issue, I guess what you're implying with that is that even though Flow may have not designed the study was designed by our esteemed colleagues. It sounds like you would like to see studies looking at Flow who have nothing to do monetarily with the organization. Is that right?
I think that would be lovely. But again, going back to the idealistic, naive view, these things are so expensive to run. I
mean, this study doesn't sound like because it's at home and requires just a bit of remote supervision. Yeah, it would be expensive, but it doesn't strike me that it would be the most expensive kind of study.
No, that's true. And potentially is something that I guess a government funding would be able to do. But I think it's, aside from the fact that it may not be realistic to expect studies like this to not be funded by pharmaceutical companies, I think you can have good collaborative relationships with pharmaceutical companies. So certainly move away from sort of a binary view where pharmaceutical companies are evil and non-pharmaceutical groups are great, because you can have problematic science either side of the coin, and people working in institutions also still have conflicts of interest. So it's okay. It's just something to bear in mind when thinking about results.
Now, I'm looking on the Boots website. I've got my Flow TDCS portable wireless headset up. 4.5 stars with 28 reviews. I'm just going to see what some of the reviews say here. Been using this for 4 weeks. Major improvement. That was 5 stars. 1 star, waste of money. 5 stars, fantastic. 5 stars, go for it, winner. 5 stars, great help. 3 stars, works for some, it seems. definitely not for me. So there's a mix of totally, non-scientific and anecdotal data from Boots. Costs £399. And what I'd like to know from you, Anya, is based on the science you have available in front of you, would you recommend this to a friend? If a friend said, hey, I'm, struggling with my mood, should I buy a Flow headset? What's your response at this stage?
I think I would say if they've only tried one other treatment before, it's worth a go.
Okay. Yeah, there you have it. And, it looks aesthetically quite nice. It does also look like it could be the center of a Black Mirror episode.
Yeah, but that's what 2025 is about.
Anything else you want to say on this study? Anything else that you think is important to mention about this? I mean, my intuition is we also need more research. So larger sample sizes, ideally not funded by Flow, as we discussed. But I mean, the way I think about depression is I think it's very unlikely that depression is one distinct, discernible biological illness. It's really, really good to have another option in the menu of options. I was on the Lively Minds podcast just yesterday. It might not feel like yesterday, depending on when this comes out. But, that's what we were talking about is, depression looks different for a lot of people, feels different. People seem to just respond to different treatments. And, if you can have a relatively easy to access treatment that you can use at home, which doesn't have risks or huge side effects, that you can try for a 10-week period. And if it doesn't work, you can move on to something else. And if potentially you could get like a government subsidy, so maybe it could be available on the NHS one day. And we know these technologies do tend to get cheaper over time, not more expensive. My intuition is probably a good thing to continue looking into.
Yeah, completely agree. I think for medications, we generally want, I think it's sort of 2 to 3 good, large multi-site trials that have been done. So, there's more work to be done when it comes to Flow. It's promising. The thing that's actually just flashed through my mind is that in terms of side effects, the only one that jumped out, and I'm not sure it jumped out in the paper, is that people did report quite a bit higher rate of trouble concentrating with Flow. So 14% in the treatment group and about 4% in the group that had the placebo treatment. Mm-hmm. So again, we don't know how kind of limited this was, how much it resolved, but I guess one that's worth people being aware of. And I think more research is definitely needed, especially to back up some of the more excitable claims that Flow have on their website. But that's always going to be the case.
All right, sounds good. Moving on, we're now going to talk about Hollywood's favorite helper for weight loss, Ozempic and other similar weight loss injection drugs like Mounjaro. The first time I heard about Ozempic and these drugs, you heard, of course, about how helpful they were for weight loss. But very quickly, you're also hearing things like, oh, it helped me stop smoking or gambling, and it affected my behaviors in different ways. And supposedly, these drugs only work on the GI system, as far as I know. That's what's understood. But as soon as you're hearing about those effects on behavior and impulsivity, you're thinking, okay, what effect are these drugs having in the brain, potentially, both on appetite and other things? This seems to be quite poorly understood. And now we have this study that's investigating, are there any kind of psychiatric complications to Ozempic or similar drugs? Can you tell us a little bit about this study?
Yeah, thanks, Alex. You're right, as in it's really interesting and a huge area of conversation at the moment for the reasons that you've said, because people are pointing out that it's having effects on their behavior, but also for reasons like we know that a lot of psychiatric medications are associated with weight gain. So having a way that we could support people with weight loss would be great, but not if it's going to lead to worsenings in their mental health when that's what we're trying to treat in the first place. So a really, really important paper, and the scientific basis for why there could be things happening outside of the GI system is that, so these drugs are GLP-1 agonists, which means that they block the effects of this GLP-1 substance that works in our brain. Yeah, exactly. And this hormone's important in our appetite, absolutely, but it's also important in, I guess, appetitive behaviors more widely.
Okay. Wow.
And so by that, we mean it is involved in the pleasure that we get from food. It's involved in potentially kind of the motivation that we have for food, but also, and not loads is known about this, but it looks like it's probably involved in motivation for other things as well. And it certainly acts, eventually, it has effects on the dopamine system in the brain as well.
Right. Firstly, I don't think I ever really had it in my head that neurobiologically appetite could be linked to motivation around other behaviors, certainly not impulsivity. And again, people report perhaps cigarette smoking, drinking alcohol, taking drugs like cocaine is influenced by taking a drug like Ozempic. And then what you just said, like there's a lot of unknowns here that for me raises a huge red flag that we're going to be starting people on these drugs. And what's going to happen in, 2, 3, 4 years down the line when huge amounts of people have taken them? What are the effects on the brain? Once we know that it's uncharted territory, for me, that's immediately a cause for concern.
I mean, some reassurance that hopefully you can have is that some of the trials testing these drugs that were run by the drug companies, I think went on for something like 2 to 5 years. So you would hope that that would pick up big red flags. But obviously we know that in drug development, the final part of drug development is monitoring what happens to the drug once it's out in the wider world. And sort of you can have, doctors and patients can report serious symptoms. Sometimes that system works well, sometimes it doesn't, but which is why studies like this one that we're going to be talking about are really important, because actually what they've done is they've looked at a community sample of people. So it's an observational study, so different to some of the studies that we've talked about before on this podcast.
So this study is partly necessary because in those previous trials you just mentioned, they're going to exclude people who have a psychiatric condition, presumably like depression or anxiety or stuff like that, right?
Yeah, they do. And unfortunately, so does this study.
Okay.
So that was one of my surprises reading it, is that actually, when I sort of looked at the title, when I looked at the abstract, I didn't quite gather that actually this study still doesn't quite help us to answer the question of how safe are these drugs in people who might have a pre-existing mental illness.
So maybe take us through what the study looked at.
So the reason that they excluded people with psychiatric diagnoses is because they wanted to look specifically at the incidence. So by that we mean how frequently were these things occurring? How frequently were psychiatric symptoms occurring? New cases, exactly. So it was a database study. So they looked at effectively electronic health records.
Yes.
It was huge. So that's, it's lovely to have these electronic health record studies because you can get really, really big numbers. And so you can have a bit more certainty that the effects that you're seeing could be approaching something like the truth.
And I guess this is a study you would call a real world study because it's patients out in the world. It's not a few very carefully selected subjects in a lab.
Exactly. So they were people who had obesity and who were prescribed one of these drugs. So Ozempic, Wegovy, there's a couple others, and sorry, not sponsored by those ones, but...
We're also, I should say, we're not sponsored by Flow either.
We're not sponsored by Flow.
We're not sponsored by anyone.
No.
That's all right.
Fully non-biased here. They basically, so they looked at people with obesity who were prescribed these drugs, and they matched them to people who were not prescribed these drugs, but also had obesity. And so that allowed them to do some really nice comparisons because they basically had a group who had the intervention, the GLP-1 drugs, and then they had a group who didn't, but who otherwise they tried to make them as similar as they could within the limitations of the fact that they weren't meeting these people, that they were purely getting their information from what's available on health records.
So similar in terms of like age, sex, other demographics.
Yeah, exactly. So age, sex, race, and any disease comorbidities that they had.
And how long did they follow these people up for?
So they looked at 5 years of health records, so sizable amount. And again, just in case anyone tuned out for any point, these people didn't have any preceding psychiatric diagnoses.
2 groups of people, one on the weight loss drugs, one not. They tried to match them. We're going to follow up their medical records for 5 years. None of them have psychiatric conditions at the start. How many develop psychiatric conditions in one group versus the other?
Exactly. You might hypothesize, because we know how good these drugs are at treating obesity. We know how much of a problem obesity can be for some people, that it's certainly associated with depression. So you might quite reasonably expect that, if these people are having really good weight loss, potentially really good management of things like diabetes that might come alongside, that their mental health ought to get better. Surprisingly, actually, that's not what happened. The rate at which people developed psychiatric conditions, and just to be quite specific, they just looked at depression, anxiety, and things like suicide attempts or suicidal ideation. So they weren't looking at things like, for example, bipolar disorder, psychosis. So they were quite narrow in what they were looking at.
Did they look at whether or not people went to A&E or whether or not they were admitted to hospital?
They didn't measure or report that specifically. The only way in which that would have been captured is if during that A&E attendance or hospital attendance, someone got a diagnosis of some kind of psychiatric condition. But that's still all that we'd know.
Yeah, so they got a diagnosis, right?
Exactly. So that's the way that the study was done, is that they, using the health records use codes. So they just pulled out the codes for obesity, pulled out the codes for BMI over 30, pulled out a code for prescribed this medication, and then pulled out codes for any kind of diagnoses that arose.
Yeah, just so people are aware, like if you're seeing a patient, you'll get a summary from the general practitioner typically. And that'll be like a sheet of every time they've been given some kind of diagnosis. And just like Anya said, there's the diagnosis and then there's a particular code. And that might apply to a condition like depression or anxiety, but it might also apply to like suicidal ideation or suicide attempt. Patient comes, sees the GP, I'm feeling suicidal, and then they get that code on their record so people are aware. And those are the same codes they're using in the study.
And automatically you can see what one of the limitations might be of a study like this, is that it lets you get really big data, really big numbers of participants, but you're limited by how good the person keeping the records is. You would hope, though, I would say, with numbers this big, that you kind of even out issues with data recording. So you would, hope that with numbers this big, there shouldn't be a difference between the two groups. So it shouldn't be that people who are prescribed Ozempic, their doctors are well better at coding their diagnoses.
Which country was the data pulled from?
From the USA.
And so what did the study show?
As I say, it was, to me, in some ways quite surprising. What the authors found is that the rates of any psychiatric diagnosis, but also if you drill down into the specific diagnosis, were higher in people receiving the GLP-1 treatment, and significantly higher. So about double, I guess, would be the takeaway headline figure. And the other thing that happened is that the rates of these psychiatric diagnoses increased as time went on. So the longer that someone was prescribed the medication, the greater the rates of psychiatric diagnoses were. So you started off in the sort of 6 months after someone started their prescription, about 9% of people had received a new diagnosis of any kind of psychiatric disorder in the medication group, and only about 4 or 5% in the non-medication group. So that's already almost double. And then as you go on to 1 year, it's 15% versus 7%. As you go on to 5 years, it's 39 to 23%. So the difference between the two groups stays the same.
And this is any psychiatric disorder?
This is any psychiatric disorder, but they were looking at major depressive disorder, so depression, anxiety, and either the reporting of having thoughts of suicide or a suicide attempt.
So that might mean, there's then a whole bunch of stuff that could be missed, like bipolar disorder or...
Yeah, for sure. Things. So we have no idea, and we have no idea about the effect on things like behavioral disorders, addictions, things like that.
That's interesting. And you said they were following the patients for 5 years?
Exactly. So it was a retrospective study. So they actually just had 5 years worth of health records that they could look back on and sort of track what happened over those 5 years.
How do you feel about the overall design of the study?
I think it's decent, it's good. What is important is that they match the two groups. So the group that received medication and didn't receive medication were as well matched as they could possibly make them. But within that then comes limitations, because actually there are limits to how well you can match it, especially if all you're using is codes, sort of electronic health data. So whilst we were sort of saying there hopefully isn't any reason why someone who is receiving the medication would have a doctor who's better at coding for them having depression than someone who's not receiving the medication. What we don't know is what level of health contacts were they having? By having the medication prescribed, does that mean that they were seeing their doctor more frequently, and so they were a bit more likely to have illnesses picked up?
Yeah, and I'd love to devote a section to just talking about hypotheses, why, which this paper can't really speak to. But before that, any other results that you want to highlight?
I think those were the key ones. It was a fairly simple paper in that sense.
Simple, but quite impactful.
Yeah, exactly.
Are there any limitations of how it was designed besides the matching that you want to mention?
I guess the limitations, again, speak to the challenges in interpreting what the causes might be. So, for example, they didn't collect how people's BMI changed over the time of the study. They didn't have information on whether people were taking the medications or not. It's
taking
definitely
the weight loss medications, loss, right?
Exactly. So to conclude that it's definitely the weight loss medications that are causing these symptoms, actually we can't do. We can say...
Would those be confounding factors? Maybe they didn't screen well enough for confounding factors?
Yeah, exactly. They are other things that could be going on that would lead to the results that we see that aren't just the fact that people got a medication or they didn't.
I'd love to think about hypotheses. Let's assume it is the case that being on these weight loss drugs increases the propensity for things like depression or suicidal ideation. Why? Why is this happening?
If we have to hypothesize, we'd probably hypothesize about the neurobiology. And we sort of started to do this at the beginning of talking, that these drugs interact with the dopamine system, which we know is important for so many different things. So it's important for our ability to learn. It's important for our motivation. It's important in some senses for our experience of pleasure, although it's probably not the most important system for that. The GLP-1 system is important, again, for experiencing things like pleasure from food. It's important in our motivation, kind of our drive for food. And if you mess with those things, you could potentially see a situation where people are less motivated to do things, where they might be therefore having less meaningful experiences because they're seeking less of those meaningful experiences.
It might kill someone's appetite for life, so to speak.
Yeah. And I think that's probably, sort of over-enthusiastic or kind of over-scary. I mean, we know, so for example, there are drugs that we use in the treatment of addiction, and also I think that sometimes get used in the treatment of obesity or sort of to help people manage food intake, like naltrexone, which works on the opioid system, which is very much relevant to pleasure. So how we sense pleasure is very much linked to our opioid receptors being activated in the brain. And what I hear from colleagues working in the addiction world is that when these drugs first came out, everyone was really scared that they would just mean that people would stop enjoying life altogether, not just that they would have slightly less enjoyment for example, alcohol or drugs that they might have a problem with. And it wasn't borne out. It's not something that patients generally seem to say, that they've suddenly stopped enjoying all things. Whether we will see that with these drugs, who knows? But it's worth knowing that...
We have to at least wonder about the possibility.
We do, especially when we see rates like this. I mean, putting it in context, I think, of sort of other papers that have been done in the field, it contrasts with similarly conducted study, so as in another large database study, which looked just at suicidal ideation, suicide attempts arising in people who were prescribed these GLP-1 drugs, so the things like Ozempic. But what they did was they compared them to people prescribed a different kind of diabetes medication. And they did also just look in people who had diabetes, so not people with obesity. Now, in that group, they actually didn't find that there was any difference in sort of suicide rates or rates of thoughts that people were having about suicide between the two groups. So it didn't look like in that study there was any higher rate of some of these issues. So that is kind of a contrasting thing. And given the way that that study was done and the comparisons that they had, makes you wonder if there's something about the drug treatment in general that, that might be important, because that second paper compared people to...
Both on drugs.
Both on some kind of drug. The last, I guess, sort of more, sort of philosophical, psychological interpretation that I was wondering about when I was reading this paper was this idea of, what is the meaning of weight and what is the meaning of weight loss and weight gain to people? How does weight loss, weight gain occur? People probably will be fairly familiar with The Body Keeps the Score, which is, sort of a really interesting book about the impact of trauma on life. And one of the case series that the author talks about is his work with women who were obese, and that when having sort of sudden weight loss after weight loss surgery that they weren't prepared for, unexpectedly their mood dropped rather than improved.
So you're saying if the obesity is in some people kind of a response to trauma, a way of self-protection, and I think what you're talking about is particularly relevant to victims of sexual assault, who may then go to food and obesity as a way of becoming more invisible to men. Is that right? That
was the hypothesis that the author of that book was presenting. That will perhaps be relevant for some people. It will probably not be relevant for others. But I guess it just leads me to think of, even in people who don't necessarily have experiences of trauma, do we need to think a bit more carefully about the obesity? Do we need to think more carefully about what's occurred in the psychological factors and actually prepare people for the weight loss in some way, or prepare people for what dramatic or actually not dramatic changes they can occur? Do people suddenly lose lots of weight, but actually life continues to be much the same? And is that difficult to cope with in some way?
Yeah, I was going to mention that. So like my two hypotheses were, one, that I think people when they're overweight or obese, they often feel like weight loss is their path to happiness. And if only they could be thin, then happiness will ensue. So one hypothesis I have, again, for some people, probably not for all or even most, would be you get that weight loss and then are you like, okay, now what? And you realize that actually weight loss only solves the problem of obesity, doesn't solve any other problems that you might have. And then the second hypothesis I had is someone is in the situation when they're obese, you have to wonder, is food perhaps just one of their only pleasures in life that they're leaning on? And if you take that away in a kind of quite forcible way with a drug, are they left then struggling to find anything that gives them some more pleasure? Again, this is probably a minority, but that's what I was thinking about.
Yeah, I think these kinds of studies are nice in the sense that they can stimulate conversation, because actually they give us none of the answers as to what it is that could be going on. And indeed, I don't think, even though the numbers are huge, I don't think we can quite say just from this study, these are definite things that will definitely happen to everyone who is prescribed these drugs. You know, we can see that from the numbers, that it's even at 5 years, it's something like a third of people are developing things, and it's still only about 20% more than in people who aren't prescribed the drugs. So it's not going to be a problem that everyone has.
And that's, again, one of the worries with these drugs is there's this sense that it's very fast, that, you know, they came around, we found out they're effective, and all of a sudden you can get them in Sainsbury's, which is very not an individualized approach and definitely not a cautious approach.
Exactly. So I think in those cases, it's way more relevant to take a study like this really, really seriously and to say, actually, like, there are risks. These aren't things that are just completely benign.
Yes.
Things that you don't expect could happen as a result of taking the drugs.
Yeah.
If you're being prescribed it in, I guess, a weight loss clinic, a study like this may feel a little bit less relevant because people are probably going to be being monitored reasonably carefully. They're probably been assessed quite carefully before they go to it. But I think having a higher index of suspicion and sort of keeping an eye out for psychiatric symptoms that are arising in your patients or in yourself is probably important.
Yeah, for users of the drug out there, just to be aware, weight loss is a big deal. It's a big psychological change. Again, it tends to be unexpected because people think, as I lose weight, actually my life will just get better. And then when people lose weight, it tends to be a lot more complicated than that. So definitely take it seriously. And then actually the last hypothesis I had about why this might be happening, and people are going to hate me, but I definitely don't, there should be no stigma in my mind or shame about using a tool like a drug for weight loss. Weight loss can be incredibly difficult for some people. It's largely a consequence of the very strange food landscape we find ourselves in modern society. But all of that being said, is there something about the struggle of losing weight and the overcoming of the struggle and the self-control and the going on the nutrition and exercise journey that adds to the satisfaction of weight loss, and perhaps to some degree diminishing that with a drug? Does that take away from the feeling of accomplishment? Again, I'm not saying this is a reason not to use a weight loss drug, but could that be a factor that's going on?
And it would still speak to one of your other hypotheses is about the time and the preparation. If you are going on that kind of journey, then you've arguably prepared yourself for the weight loss more. Although, having said that, I can imagine that people who get to these drugs have probably tried a lot of things before and actually perhaps have tried the kind of journey and battle that you described.
And even if you're using one of these drugs, super important to have a nutrition plan, super important to keep your protein intake up, super important to have a nutrition plan for when you're off the drug, because that's crucial, otherwise you gain the weight back. And then very, very important to do strength and resistance training when you're on the drug to reduce loss of muscle mass, bone density. It's a huge problem with these drugs because my understanding is a lot of the mass loss isn't just fat. It will be fat, but also bone, muscle. So you definitely want to be training when you're on these drugs. I'm curious, how does this paper influence you as a practitioner? Does it change anything? Does it make a difference now if you have one of your patients walking into the clinic and saying, I'm thinking about trying one of these drugs?
I think, and this speaks to one of the very first points that we made, you know, in some ways I'm disappointed by what we can't quite know from the paper, which is what can we say to our patients who are walking into psychiatric clinic. And I had a look, and actually someone can hopefully pop their hand up and correct me that there is a similar beautiful paper that's been done in people who did have pre-existing psychiatric diagnoses. But as far as I know, there's not really that much that's been done. There are a couple of studies that are currently ongoing that are recruiting where they are specifically testing people who have, for example, a diagnosis of psychosis and who are on medications that are linked with weight gain, and they're testing these drugs in those patients, which is fantastic. That'll be so helpful. But yeah, lots of the papers that are out there basically excluded people who had psychiatric diagnoses. The few that didn't do again hint at the fact that there could be some worsening, at least in things like sleep, so higher rates of insomnia. So I think I would be cautious. I think I would give the person the advice and this exact explanation to say, look, it looks like they might be associated with slightly higher rates of things like depression, anxiety, experiencing more suicidal thoughts. The latter, the suicidal thoughts, suicide attempts are a really, really rare event. So in any case, it's unlikely that this would affect you. But depression, anxiety were happening a bit more commonly. Keep an eye on it. The authors in this study mentioned 2 case reports where someone had a very clear depressive episode that occurred just after starting the drug. And in those patients, actually, their symptoms got better when they stopped the drug within about 2 weeks. So you can even do a bit of a trial and test. If things get worse, you can stop the drug, see if it gets better. And that gives you, like I guess in all of medicine, a slightly better idea that it might be the drug that's the problem.
More research will be done and we'll keep a lookout for it.
Absolutely.
Moving on to our last and strangest study of the episode, we're looking at whether or not hydrogen-infused water can reverse aging. You might be wondering, how did you find yourself looking at this study? I was listening to the Joe Rogan podcast, and he had a guest on, Gary Brecker, a biologist who, should be noted, sells hydrogen water. And if you listen to a lot of podcasts like I do, very frequently you'll hear some scientist who also sells something talking very, very confidently about a study and, talking about it with absolute certainty, similar to like the kind of Tony Robbins study we mentioned in the last one of these episodes. And finally, I have a platform where I can look at a study and discuss it in depth, and we can actually find out, is this just marketing or is this a study of substance? So Anya, take us through this study. What did this study look at?
This was a study which looked at whether drinking hydrogen-enriched water would positively impact on aging. So they looked at people who were 70 and older.
Yeah, it was published in the Journal of Gerontology.
It was. And they looked at 40 participants in total. They had 34 people who actually completed the study. We don't actually really know what happened to the 6 participants who didn't complete the study. It had a design where half the people received the hydrogen-rich water, half the people received a placebo control water. Now, that's a good start. That's sort of, as we've talked already, that's what you want them to do. But you'll see that the difference in numbers from the first study that we talked about. So 20 in each group is small. And actually, the authors are very open about this. They title the study as a pilot trial, which is exactly what it is. So at those numbers, you would say that this is either a feasibility study or a pilot trial. The aim of such a study is to help prepare you for a larger study.
Fair enough.
So you test out your processes, you test out your procedures, you check whether you can actually run the study. You maybe check whether there's a hint of an effect that it's worth following up on, but you are really prepared for the fact that you can't make any strong conclusions on the basis of a study like this, which is really interesting when you then see a YouTube video where someone says that this is sort of a definitive, fantastic study that clearly shows that there are some really obvious benefits. So that's a shame, because I think from the get-go, we can say we really can't make conclusions like that with a study like this.
So what did the study show?
So they got people to drink this hydrogen-rich water for 6 months. They had it twice daily. And they found that there were a few things that would maybe link with positive impacts on aging, but actually lots of things that just showed no effect.
Okay.
So they measured loads and loads of outcomes. They didn't do what we call a control for those multiple comparisons. So that's sort of key quality point number 1 that I would say. Now, you wouldn't necessarily do that kind of control in a pilot study. So because in a pilot study, you're trying to work out if things work or if they don't, you might just kind of run loose and free with all your possible outcomes. But, and think about it this way, say you've got a jar of sweets and you want to find the yellow sweet, and there are sort of a few yellow sweets in that jar, but you don't know how many. If you dip your hand in once, your chance of getting a yellow sweet is pretty low. If you dip your hand in 10 times, you're that bit more likely to find a yellow sweet.
So the more outcomes you look for, the higher the likelihood that you find something.
Exactly. And the chance that you're finding something that is just happening by chance rather than because there is a true difference between the groups is that much higher. So what you would usually do, especially if you're running sort of a big proper study, is that you would say, I will do some kind of adjustment to control for the fact that I have dipped my hand in 10 times.
Okay. How do you adjust for that?
So the simplest way is you just divide your level of significance by the number of comparisons that you've made.
So there's a statistical process.
Exactly. There is a level of statistical significance at which we accept that results are not occurring by chance.
Okay.
That level is usually less than 0.05.
Yeah.
So if you're reading a paper and you see sort of a P with a less than sign and it says less than 0.05, that's sort of the standard notation and the standard measure that's kind of used. But what you might do is you say, okay, I've done 10 comparisons, so I'm going to divide that level by 10, and I'm now going to embarrass myself with not being able to do maths on the spot.
So it'll be less.
It'll be less, exactly.
And therefore harder to achieve so-called statistical significance.
Exactly.
So they did a whole bunch of outcomes. Did they adjust it?
No.
Oh.
I know. But as I say, it's not necessarily terrible to not do that in a pilot study.
Okay.
But it is dodgy for somebody to not then be careful with interpreting those results. So we're going to be careful with interpreting the results. Okay. Now, I'll start with the negatives because they're kind of the simplest ones. So they didn't find that there was any effect of having hydrogen-rich water on cholesterol, glucose metabolism, inflammatory markers, sort of exercise measures that they used, or blood pressure. So these are all things that you might expect to be a problem when it comes to aging. The question that arises really is whether you would necessarily expect to see huge differences in those things just over 6 months. But they're kind of useful things to look at. When we're talking about the exercise markers, it's things like how fast people could stand up from sitting, how well people could do different sort of walking exercises, things that I think are fairly standardly used in elderly care to measure someone's functional status.
Okay.
So nothing there. They did find some differences on, I guess, some of the more internal markers of aging. So one of the things that they measured was telomere length. Now, if there is anyone listening who is a geneticist or who is a specialist in telomeres, please forgive me.
And I do want to say, looking at this study, which was kind of a whim on my part, it did make me realize how important it is to have a background in the field that you're studying to interpret it. Because when we talk about mental health studies, I feel like I'm much more confident in interpreting the results and knowing what that means. Here we're looking at an aging study. That's not my field, that's not Anya's field. So we are flying a little bit in uncharted territory. But telomere length, you said, is quite a commonly used marker of aging? Good
question. I don't know that it's commonly used, but I guess it's commonly talked about because, and this really I just remember from medical school, is that our telomeres shorten as we get older. So that's one of the things that's very much associated with aging. Now, the caveat that I would put to that, which I think is quite interesting, is that just having longer telomeres isn't necessarily a good thing, because in some cancers, what happens is that the way that the cancer interacts with cells is it actually prevents telomeres becoming shorter, but it just means that those cells are becoming cancerous cells or are more cancerous than the other cells. So it's not just a case that lengthening your telomeres is going to mean that you live forever.
Right.
But it's something that's an area of exploration kind of in the field of aging as to, we can see that it's associated with aging. So does reversing it in some way, does it make a difference to aging? They did find a small increase in telomere length between the control group and the active group. But I guess, so with what I've said, whilst this could be a positive signal, we just don't necessarily know what the relevance or importance of that is to aging. So I think to say that this increase in telomere length is a really positive sign of drinking hydrogen-rich water, I don't think we can say. The other thing to say is that actually what we also don't know is what the function of the increase in telomere length is. The other thing that they found was that they had a difference in the TET2 expression. Now, have you been revising? Do you know what your TET2 is?
I don't. I was really counting on you.
Yeah. So it's, and again, I'm going to put this in the simplest terms that I kind of have managed to understand, is that it's something that helps to keep things steady when it comes to cell maintenance.
Okay.
But again, the caveat with this is that they measured TET2 expression. So they measured sort of the amount of the genes related to TET2 that they could measure in people's cells. It will become clearer when I say this last point, is that, so we don't know if it's functional. So we don't know if the increase that they saw in TET2,
if it means anything.
And if it leads to a change in function. Exactly. And the other caveat with this is, so whilst you could kind of tout this as, multiple markers of aging were improved by hydrogen-rich water, actually, in this case, the baseline levels that people started with were quite different between the two groups. So people who got the hydrogen-rich water had a very different baseline level of the TET2 compared to people who got the control water.
Okay, right.
And what that's probably speaking to is just that because this was such a small study, because the groups are so small, there's natural fluctuation, natural individual difference. And so therefore you're just picking up that natural variation rather than any kind of meaningful difference.
So we've got telomere length, got TET2 expression. What's next?
And then we've also got some changes in brain metabolite levels. Again, for me, the significance of this is just really unclear. I don't know that we can say that this is in any way linked to healthy aging, unhealthy aging. It's just that they picked up some slight differences between some of the neurotransmitters that we can pick up in the brain.
Okay.
The last thing that on the range of senior fitness tests that they did, so where they got people to do different exercises, the one significant difference that did come out was what happened on the chair stand test. And here they did find that there was a small difference between people who got the hydrogen-rich water and the people who didn't. Again, the caution that I would put on that is that at the start of this, the people in the hydrogen-rich water group started with a lower score than the people who were in the control group. And actually the score that the people ended up in the hydrogen-rich water group, which is so 11.6, actually doesn't sound that different from the 12.5, which is what the people in the control group got. Okay. So it's an interesting study. There's enough there that you would say it's probably worth repeating to see if with, bigger numbers, bigger groups, you might get more clear-cut results, whether you might cut through some of that just natural inter-individual variation that occurs. But to say that, this clearly points to hydrogen-rich water being something that we'll
all be drinking in 10 years.
Yeah, or that this is the way to fix aging, that this is the way to healthy aging, definitely too much.
I'm on Gary Brecker's website now, and you can buy 30 unflavored dissolvable tablets of molecular hydrogen tablets. I don't know why they would put the word molecular there, but hydrogen tablets for $29.95. You can recur that every 30 days on a subscription model. Based on this study, are we going to buy or no?
Absolutely not.
I'm going to know. Now, I know you looked at briefly a larger review of the literature around hydrogen therapy in other contexts, looking at other studies. What does that point to?
I think it points to this being an area of interest. I mean, I didn't analyze any of the individual studies in that bigger review in any kind of detail. But the things that would say that it may be worth being interested in this is one, thinking about the mechanisms, and two, I guess, thinking about other gases that we know are relevant in healthcare. So what hydrogen water is doing is it's giving us hydrogen gas into our bodies. And so the thing that we are interested in having an effect on us is hydrogen gas. Now, we know that there are other gases that do have roles in healthcare. For example, nitric oxide is one we use for sort of pain relief. Oxygen, obviously, we need. So it looks like there are potentially interesting roles for hydrogen when it comes to things like cardiovascular disease, that it may have an impact on our blood vessels, on our vasculature, which is what Gary Brecker talks about in terms of being the possible mechanisms for this in aging. So there are routes to where this could be relevant.
One thing I'm curious about, I don't know if you watched any of Gary's content talking about it. Mm-hmm. If you have, do you feel like he's talking about it with too much certainty? Because that's really one of the things I'm interested in. It sounds like there's enough scientific evidence that, hydrogen therapy is a good area to research more. But if you have watched Gary's content, does it seem like there's a disparity between his level of certainty, given that he sells the stuff, and the actual science?
Yeah, absolutely. I think especially considering that this study that we've discussed is one of the main ones that is quoted by him. We didn't mention this point, but I think it wouldn't be a surprise to anyone that this aging study was funded by a producer of hydrogen-rich water tablets.
Right. Red flag. And in this case, we don't know about the role of the funder in the analysis or the conduct of the study. So it's not reported in the paper. So you would usually expect a line like the funder had no role in the design, collection of data, analysis, or interpretation. We don't have that here. So who knows what was happening? And we can only worry that it might have been something nefarious. But
certainly there isn't enough there to be confident or to say that everyone should buy hydrogen-rich water tablets.
Wonderful. Thank you so much for joining me, Anya. Today, I learned about science and I had fun. Thank you for listening, and we'll see you here next time.
Bye.